So really pre-COVID and before, when we started thinking so much about telemedicine and how it was going to serve the broad spectrum of our population, we were thinking about how we could use telemedicine as a way to serve patients in our communities who don't otherwise have access to the care that's provided at our main Mass Eye Near sites. So despite the fact that Mass Eye Near is located in central Boston, there are many communities just really on the outskirts of Boston that are underserved populations, both in healthcare and in ophthalmology. So for example, there are community health centers that have very high levels of diabetes, and we know that only about half of the patients there are getting yearly diabetic retinopathy screens, despite the fact that that's recommended for everybody. And so a year ago, I was able to get a grant from Mass General's community health sort of executive committees, and what they do is they sponsor sort of outreach into the community, particularly of subspecialties. So we have a grant that we can go into Chelsea Community Health Centers. It's a Mass General health center, and Mass General is one of our affiliates. And we were able to purchase Optos imaging to take photographs of patients who have diabetes in those health centers, screen them, read those images back at Mass Eye Near, and then result and provide follow-up to patients as they need it to make sure they're getting an adequate care and sort of the same level of care that they would get within Mass Eye Near. This is something that so we sort of started off small in diabetic retinopathy, but have lots of plans to sort of grow, and you'll hear about that from other panelists tonight. But there are so many opportunities for using telemedicine within the community to bring healthcare into the community, and in many different ways. So to look at diabetes, but also to look at glaucoma, to screen for other pathologies that result from different medications. And so what we're working on now is screening for diabetic retinopathy in those centers, but we have plans to expand that and really bring full service clinics into the community, into community health centers in the future. And I'll talk a little bit more about this in sort of in questions moving on too, but this is something that we're very interested in getting residents involved in. So I think it's a way that residents can learn about telemedicine, but also can learn about what's going on in the community healthcare and healthcare disparities.
Yeah, our research is focused in parallels with Alice. We work very closely together on many projects, but some of it centers around subspecialty delivery of care. And I think a lot of telemedicine is sort of screening absence or presence of disease, but as we try to refine our workflows, we're trying to determine the urgency at which a patient might need to come in to see a provider to get treatment, injection, or surgery. And so really working particularly in diabetic retinopathy using the latest and greatest advanced imaging. We have ultra wide field photographs with typically the Optos, based a lot at Mass Eye Near, as well as other locations throughout Harvard Ophthalmology, to really screen for peripheral lesions. So we're really working on a few different things, including image quality control. I mean, this is a big problem. These devices are usually operated by non-ophthalmic technicians, so trying to have user feedback as to whether additional photographs need to be captured or if it's of sufficient quality for grading to help streamline the process. A lot of images are non-gradable in traditional telemedicine systems. We're also looking at machine learning algorithms to kind of link OCT, or optical coherence tomography, with those fundus photos to better differentiate the disease in patients. And then in kind of a completely different vein, we were also doing some early work with the concept of telesurgery. So we're fortunate at Mass Eye Near to have Ingenuity, which is a 3D display, heads up 4K resolution, 70-inch monitor that you can operate. It takes away from the microscope. It's been really great for residents and medical students. Everyone's seeing the same surgical view in the room, including the nurses and scrub techs, and it really has improved communication both in the room, but because of that high quality video, we're able to stream that to other locations. And we've had a proof of concept over a year ago with Verizon 5G transmitting to another location. And now we've, with other devices, have kind of shown you can go to other cities, other states, and even internationally to other countries. So you can imagine these types of applications for mentorship or proctoring of less experienced surgeons in more remote locations. I think it is really going to shift both clinical and surgical care.
Virtual visits at Children's took off about 4 years ago in November of 2016, and it has a long history. So my involvement started sort of at the end of my fellowship, I started noticing that my mentor, Dr. David Hunter, who is the chief at Boston Children's Hospital, used to see a lot of international patients. These patients would fly in, have surgical intervention, and then fly home. And he would do a lot of the postoperative care via video and photographs that the families would email in. And we would know exactly what to expect in the postoperative case. And he would then counsel a local physician if there was a problem, or just counsel the family over the phone. And it worked quite nicely. And so we started clamoring, and I started asking my patients to send in photographs, even if they lived down the street, because it's a lot easier than coming in, parking, coming upstairs, waiting in the waiting room, and waiting 2 hours for me to tell them, everything looks great. See you later. I'll see you in 2 months when everything's healed. And so with this came the idea that other specialties across the hospital wanted to do virtual care. And the Children's Hospital put together a team through our Innovation and Digital Health Accelerator to develop our virtual visit program. And like I said, that launched in November of 2016. Ophthalmology, I'm proud to say, was at the forefront of developing this technology, and our leadership was very interested in being part of it. And so I got to help and to work with urology, and think back to my med school days, neurology, neurosurgery, all these different specialties, and really be part of the hospital in developing the system. So up until about February of 2020, right before the pandemic, we were doing anywhere from 300 to 500 virtual visits across the hospital, with ophthalmology being, about 5% of those. And since then, it's just taken off, and I think we'll have the opportunity to talk a little bit about that. But I found it really fun to sort of be at that forefront, to work with the rest of medicine and see how we overlap and what different things we need. And so I think all the things that you heard from the other speakers are sort of the future, and where we're going and how we can employ this in ophthalmology.